Good evening, everyone. It is now 7 p.m. Eastern Time. Thank you for joining us for the Canadian Liver Foundation and the Canadian Association for the Study of the Liver webinar on cirrhosis. My name is Nem Maximovich, and I will be the moderator and host for this evening. We are pleased to be joined tonight by our two presenters. We have Dr. Amin Ben-Masoud from McGill University in Montreal, and Dr. Puneeta Tandon from the University of Alberta in Edmonton. For our agenda, we will have our two speakers complete their talks prior to moving to a question and answer portion. Please feel free to use the Facebook chat feed to ask any of your questions during the presentation. Please note that questions will be answered following both speakers' presentations and talks. This webinar will be available post-event on the Canadian Liver website, that's liver.ca, as well as our Facebook and YouTube pages in the coming days. For those of you who may not be familiar with the Canadian Liver Foundation, we were established in 1969, being the first organization in the world created to help people with liver disease. We are committed to promoting liver health and improving the prevention, diagnosis, and treatment of liver disease through our four core pillars: research, education, patient support, and advocacy. Our partner at the the Canadian Association for the Study of the Liver is also a nonprofit organization that seeks to eliminate liver disease through research, education, and advocacy. Its members include a wide amount of individuals in terms of specialties: liver specialists, gastroenterologists, pathologists, pediatricians, radiologists, scientists, surgeons, trainees, and amongst others. At this time, I would like to welcome our first speaker of the evening, Dr. Amin Ben-Masoud. Dr. Ben-Masoud completed his medical degree, internal medicine residency, and gastroenterology training at McGill University in Montreal. He went on to pursue fellowship training in hepatology at the Sheila Sherlock Liver Cancer at the Royal Free Hospital in London, UK. His primary clinical and research interests are portal hypertension and vascular liver diseases. His research will focus on the development of new methods to diagnose, stage, and monitor portal hypertension using invasive or non-invasive tools. I will now hand it over to Dr. Ben-Masoud for his portion of the talk.
All right, thank you. Thank you, Nem, for the presentation. We'll share my screen. All right. Well, good evening, everyone, and really thank you for being here. It's an honor and privilege for me to be part of this educational webinar on cirrhosis. As mentioned, my name is Amin Ben-Masoud. I'm a hepatologist at McGill University Health Centre in Montreal, Canada. These are my conflicts of interests. And so I've been asked to cover a few little things for us at the beginning, including what does the liver do? What is cirrhosis? What are its causes and symptoms? How is it diagnosed, and what are its stages? And I hope you'll find this very useful to you. So I do want to mention a special thank you to my co-presenter, Dr. Puneeta Tandon, and her team, who's behind a truly wonderful website called cirrhosiscare.ca, who's truly an amazing resource for everything and anything that's liver related. So a lot of things that I'm going to discuss this evening comes directly from this website. So thank you, Puneeta. So what does the liver do? I think that's a great question that's been intriguing individuals for millennia, starting in ancient Mesopotamia, where the Babylonians and the Assyrians, about 4,000 years ago, thought that the liver was the seat of the soul. So much that they actually were using it for divination or trying to predict the future based on the different characteristics of a sheep's liver. And as you can see on the right side, clay liver model from 4,000 years ago that was found in Mari, Syria. And then a bit later on in ancient Greece, or Greek mythology, it was thought to be quite difficult punishment. And some of you might know the myth of Prometheus, who was sentenced by Zeus to be chained and have an eagle come to him and eat his liver every day. That would be quite a gruesome punishment. And then if we move a bit closer, it was considered to be an undeniable proof of death by the Grimm brothers, who I don't know if there are any Snow White fans, but the evil queen did say to the huntsman, "Take Snow White out into the woods to a remote spot and stab her to death. As proof that she is dead, bring her lungs and her liver back to me. I shall cook them with salt and eat them." This is the earlier version of the 19th century, which was slightly adapted later on by Disney, where the lung and liver were put aside for benefit of the heart. Regardless, little factoids about the liver: it is the largest internal organ of the body. It is located in the right upper quadrant in the abdomen, behind your ribs. It weighs on average about 1.5 kilos, which is about 3 pounds. The interesting thing is that it does receive about 1/4 of the blood that's flowing through the heart every minute, which is about 1.5 liters. Another interesting fact about it is that it receives blood from 2 areas. First, the hepatic artery at about 30%, and the portal vein and the remainder in 70%, which is going to be important, as you'll see right after. So the portal venous system, which is the portal vein, which is located, here in blue, brings blood to the liver. It's composed of 3 major veins, which is the superior mesenteric, the inferior mesenteric, and the splenic vein. Together, they basically drain the entirety of the gastrointestinal tract below the diaphragm, from the stomach, the small bowel, and the colon, but also including the spleen and the pancreas. This means that everything that you ingest, whether nutrients, vitamins, electrolytes, and so on, make it to the liver in this direction. The liver is a critical organ, and so as you can imagine, because of its proximity with the GI tract, it's involved in detoxification and also metabolizes different toxins, whether it's medication, drugs, but also ammonia and sometimes bacteria. It filters the blood to regulate circulation, and also it's involved in the production of key proteins, which are involved in clot generation. It's also a powerhouse that's involved in the manufacturing of useful products used throughout the body. For example, glucose, which is the primary energy of the brain. Also makes proteins, amino acids, but also can reconstitute fats. It's also an important storage of glycogen, which is basically a polymer of glucose or multiple little glucose stuck together. It makes bile, which is a key component that helps digestion of food and also participates in the absorption of fats, including fat-soluble vitamins, such as vitamin A, vitamin D, E, and K. It's also involved in the regulation of the body's temperature and is also a key player which is involved in the conversion of a thyroid hormone from a less active form to a more active one. So what is cirrhosis? From the ancient Greek word, actually, kyros, which means tawny, which is sort of the color, this yellowish color that it has. And so really, cirrhotic liver is really a scarred liver. And so through time, as the liver becomes damaged or injured, it leads to the formation of scars. The more scars there are, once the liver is replaced by scars, it shrinks and becomes hard. And you can imagine when that happens, the liver is no longer able to do its usual function. And you can imagine as similarly as if you have a cut on your skin and that you have a scar formation following that, the scar tissue itself is different from the skin around it, and it has different properties and is non-functional. And this is similar to what happens within your liver. And one of the important aspects is that with cirrhosis, unfortunately, comes portal hypertension, so high pressure within the portal venous system. And this you can imagine as, for example, a liver, which is normal and has blood flowing through it very easily. If it becomes scarred and replaced by what could be considered a rock, for example, well, blood would have a much harder time getting through. And this is what would cause a backup of pressure. And obviously, blood needs to find a way to make it back to the heart, so it needs to take different detours around the liver through other veins. And so with portal hypertension, you start developing these varices or other collaterals. What are common causes and symptoms of cirrhosis? These are sort of the top 3 that we can consider. So alcohol, non-alcoholic fatty liver disease, but also hepatitis B and C. We also have other less common causes, including autoimmune hepatitis, which is an overactivation of the immune system that targets hepatocytes or liver cells. We also have other causes such as biliary cause of cirrhosis, including primary biliary cholangitis or primary sclerosing cholangitis, which is also part of it is probably thought to be due to dysregulation of the immune system, leading there to dysfunction in the bile ducts. There are also other diseases that are either genetic or hereditary, such as hemochromatosis, which is involved with iron overload, Wilson's disease, which is involved with copper overload, or alpha-1 antitrypsin deficiency. And as you can imagine, with this, you can sometimes have more than one cause of cirrhosis. Just to go through the most common ones, so alcohol. As I said earlier, everything that's ingested by your GI tract makes it to the liver, and that's similarly for alcohol. But the liver can only detoxify a certain amount at a time. And when the capacity of the liver becomes overwhelmed, that's where damage starts. And this often starts with what we call alcohol use disorder, which is considered to be at least more than two standard drinks for women, or 3 standard drinks in men, which is, for example, you can consider about 4 ounces of 12% wine, or a can of beer, or of a 12-ounce can of 5% beer are considered standard drinks. And so whether it's daily alcohol use, but also binge drinking, can lead to fat deposition within the liver, so alcohol-related fatty liver, or also when inflammation happens, so hepatitis, so alcoholic hepatitis, which can then also progress to cirrhosis. Another major cause is non-alcoholic fatty liver disease, which is abbreviated as NAFLD, which is a growing cause of liver disease, which in and of itself is considered to affect about 24% of the population in the United States, probably not that much further off here in Canada, and is closely linked with obesity, diabetes, high blood pressure, and cholesterol, which are considered metabolic syndrome. This is often associated with an increased presence of accumulation of fat within the liver, and fat at some point also becomes toxic and leads to inflammation, and this is what we call non-alcoholic steatohepatitis, or NASH, which is considered to affect about 5% of the population. And so this is the usual trajectory, where you kind of start with a normal liver, and then a liver that develops fat deposition to it, or excessive fat deposition, inflammation to NASH, and then can lead to cirrhosis. Hepatitis B, quickly, so it's a double-stranded DNA virus, which affects about 260 million carriers worldwide, and nearly 500,000 here in Canada. It's transmitted by blood and body fluids, so there's often considered difficult maternal fetal transmission, injection drug use, or contaminated equipment. This can lead both to an acute hepatitis or chronic hepatitis. Interesting fact is that it's more likely to become chronic if you're infected in infancy, and less likely so if you acquire it during adulthood. Thankfully, this is very easily and readily detected through simple blood tests, which look at antibodies against hepatitis B or DNA levels. Hepatitis C on its side, it's an RNA virus, which affects 7 million individuals worldwide and about 200,000 here in Canada. It is transmitted by blood primarily through injection drug use, previous transfusions, or contaminated equipment again. It can present in a gamut of array of reasons, so either fulminant hepatitis, acute hepatitis, or also chronic hepatitis. And similarly, thankfully, it can also be easily detected through blood tests looking at antibodies against hepatitis C or RNA level. So it leads to symptoms of chronic liver disease and cirrhosis. Unfortunately, this is one of the difficulties, is that most of the time there are actually no symptoms associated in this, even in the early stages of cirrhosis. And often when someone does have symptoms, these are often quite vague, and they can go from anything like lack of energy or fatigue or drowsiness, poor appetite, weight loss and muscle loss, depressed mood or loss of sexual function, aches and pains, but also dark urine or pale stools, and sometimes itchiness or yellowness in the eyes, which is called jaundice. So how can we diagnose it? It's often a combination of history, physical exam, blood tests, imaging, or biopsy. And so on the right side, you can see what we call spider angiomas, which are these red-shaped structures that you see here on the skin. And when you press on them in the center, they sort of disappear. And then when you remove your finger, they reappear from the center towards the outside. Called spider angiomas because they do look a bit like spiders, and once you have more than 3, that is considered abnormal. Otherwise, there are also blood tests can be done to rule in or rule out cirrhosis, such as the AST to platelet ratio, fibrosis 4 or the NAFLD fibrosis score. But unfortunately, sometimes you can be left with a large number of indeterminate results, which you might need secondary testing to rule in or rule out cirrhosis. The good thing about these is they're easily done through simple blood test or body measurements. Then we often rely on imaging studies, whether it's ultrasound, CT scans, or MRI. So in this picture here, you can see on the right side, presence of a liver, which is, if you look at the contour of it, is nodular, or it's not smooth, which is another sign of cirrhosis. And around it all is this dark black shape around it is actually water accumulation, fluid accumulation within the abdomen, which is called ascites. Similarly, this is another picture here where you see, this is a CT scan where you see the liver in this area here, so again, not very smooth and a bit nodular, with here this vein that's open, which is atypical, again related to presence of portal hypertension. So very subtle findings that can be looked at. Back in the day, we also used to rely quite a bit on liver biopsies. And here you can see from the leftmost biopsy to the right side, with increasing amount of scarring, which is represented in blue. You see more and more depositions of scars, which give this liver appearance of sort of little nodules. But now we have more non-invasive techniques, which we can also rely on, called elastography, which relies on the physical property of the liver. As you can imagine, as the liver scars or becomes more stiff, the values increase. And so here, over this graph, you can see that we can often convert this numerical value of liver stiffness to grading, a staging of scarring deposition within the liver, similar to what we used to have with liver biopsies. So what are the stages of cirrhosis? So initially, cirrhosis is often asymptomatic, or especially in the compensated phase. But still, that remains that the presence of compensated cirrhosis is a risk factor for liver cancer. But as the disease, the presence of swollen veins within the esophagus or varices. As the disease progresses and you lead into decompensated cirrhosis, which is often most likely driven by portal hypertension, you have a high chance, again, of developing liver cancer, but also fluid accumulation within the abdomen in the form of ascites, bleeding from the swollen veins, or variceal bleeding, or confusion, which is called hepatic encephalopathy. And these are cornerstone presence of a decompensated cirrhosis. So these are often considered as the sub-stages of cirrhosis. So stage 1 in compensated cirrhosis, where there's no varices. Stage 2 is when varices appear, but they have not bled. And then decompensated cirrhosis occurs when sort of stage 3, where you have bleeding from one of these varices. Stage 4, when you have another type of complication, which is not bleeding, so either ascites, which is actually the most common type of complication, or hepatic encephalopathy. And stage 5 occurs when you unfortunately have developed two complications, two decompensation events from liver disease or cirrhosis. Thank you. That was it for me.
Thank you, Dr. Benmasu, for that great talk and great outline. I think we're going to move on and introduce our second speaker for the evening, Dr. Punita Tandon. Dr. Tandon is an associate professor of medicine, co-director of the Cirrhosis Care Clinic and transplant hepatologist at the University of Alberta, Edmonton. Her clinical practice and research are focused on cirrhosis, with diverse research interests including cirrhosis-related complications, frailty, palliative care, and digital solutions to provide nutrition and exercise interventions, as well as mind-body therapies such as yoga and meditation. She is the lead of the Cirrhosis Care Alberta Project, a provincial initiative focused on improving quality of care and outcomes with patients with cirrhosis. It is her career goal to provide holistic, interdisciplinary, patient-centered care through evidence, education, empowerment, engagement, and teamwork. I will hand off the mic here to Dr. Punita Tandon.
Thank you, Nam, and thank you so much for this invitation, and hello to everybody out there. Nam, I'm going to share my screen. Just let me know if that works. Can you see that okay?
Yes.
Okay, wonderful. All right, so thank you for that great talk to start with. And I have been tasked with speaking around management, the management side of things. So to do that, I didn't on purpose prepare any slides. I thought I would take you through the website that Amin has mentioned in his presentation. And so you can go to it by going to cirrhosiscare.ca. And I must thank the large team that was involved with building this content. So in addition to sort of the core team, you can see that we have a patient lead, as well as many physicians and other allied health specialists, and our patient partners as well, who have contributed to this website. So 20 minutes is not a lot to cover all of the management of cirrhosis, but be assured that you have a resource that you can certainly look at to get more information. So when you go on the website, what you'll see is the patient and family resources side. So I'd encourage you to click on there. There is one piece of orientation I'll give you that you can sort of make the most out of the website, is to log in. And if you log in that way, you will get access to pre-tests and post-tests with some educational material that we've got. And that'll help us to learn how we can make the materials better as well. So that's an opportunity. And then just to orient you a little bit here, the top purple, there's lots of purple on the website, but the top purple goes through all the menu bars. And so there's lots of different topics going all the way from what the liver does, all the way to support for Albertan patients. This was developed in Alberta, but by no means, most of the resources are for everybody, and it goes through procedures as well. So I'm going to use this, and we're going to learn a little bit about the management. I want to start just with the stages of cirrhosis, and so that's a page. And so Amin did go through the fact that we have compensated and decompensated disease, and that's important to know. And so compensated cirrhosis, like Amin mentioned, you may not have any symptoms, or you may have symptoms. We know that certainly it can impact quality of life to have compensated cirrhosis. It can cause low energy. It can reduce your muscle mass, etc. So just because you don't have those major liver-related complications, there certainly can still be an impact. Having said that, many people do remain asymptomatic, and it sometimes is a surprise to them when they get diagnosed with compensated cirrhosis. Now, when you go into decompensated cirrhosis, this is more clinically obvious. So I just reinforce what Amin was saying about the fact that people will get then ascites, or that fluid buildup, or bleeding from veins in the food pipe, or confusion. So liver-related confusion, which is called hepatic encephalopathy. The next page I want to take you to is living with cirrhosis. Okay, it's a scary diagnosis when you get it, and clearly it has major impacts not only on physical health, but also on emotional well-being for the person who has it, as well as for their family members. And so this video, our patient partners and our team have put together just to say, listen, there are things that you can actually do to empower yourself and to become involved in your care. And so this video is 4 minutes, so I won't be playing that one. But just to summarize some of the most important things I think that you can take back control over is to really learn about the common complications of cirrhosis, so you know what to watch for. And in particular, if you have a more advanced disease, to know when you need to potentially go to the emergency department. And so there's a page about just dedicated to that as well. Amin mentioned the various causes. So there's so many different causes, and certainly one thing that your liver specialist will do when they meet you is figure out if there is something that can be reversed. And so if they can start you on treatment for autoimmune hepatitis, or for primary biliary cholangitis, or get rid of your hepatitis C, which is now very possible, they will do that if that's possible. There's other things as well, like avoiding alcohol. So Amin mentioned that as a major cause of liver disease, but even if your cirrhosis wasn't caused by alcohol, a recommendation by the guidelines and by most experts is that everyone with cirrhosis should ideally avoid drinking alcohol. To learn about the medications that you're taking and understand that various medications that you take over the counter can also cause harm potentially. So things like Advil or ibuprofen that you might take for pain, that can be dangerous for the kidneys. In addition, it can increase your risk of bleeding. Many patients still come to me and say, oh, Tylenol, I can't take Tylenol. My doctor told me I can't do that. But you can take Tylenol. It's actually a safe medication provided you don't take too much of it. And so the recommendation is no more than 2 grams a day. So that's 4 extra strength Tylenol a day, obviously only if you need it and not when you're drinking alcohol. That can increase the risk of toxicity or damage. And then there's a link obviously that goes through a few more of those kind of herbal medications and other medications as well. Keeping regular appointments, as hepatologists, we do give our patients a fair number of appointments, as far as even follow-up appointments in virtually or in person, as well as ultrasounds and blood work. Ensuring your immunizations are up to date. And so now in this COVID era, I mean, absolutely, I would stress anyone who hasn't been vaccinated should be vaccinated. People with cirrhosis are at increased risk of having more severe complications if they do present with COVID. So take the opportunity to protect yourself, and then really building, if you can, that awareness about the disease amongst your family and friends. I think that's so important not to go through this alone. And so even sharing with them resources that they can read so they can better support you. Okay, so that's the main stuff I wanted to cover on there, but you can see there's many other things. And now I want to touch on the main complications. So we're going to try and see if a video will work. But first, all of the pages will look like this. So it'll give you an idea of when to go to emergency for these complications. It'll also give you a video link, and I've made a shortened form of it, 1-minute videos that we'll go through in a sec. And then it'll go through a lot of information about the condition and about the treatment, in addition to little videos about the different treatments that we might run into. So ascites, as Amin mentioned, is fluid buildup in the belly. So let's watch this video, and Nem, please tell me if it doesn't play well.
Your healthcare team will ask you to lower the amount of salt or sodium in your diet. You should take in less than 2,000 milligrams each day. This will help lessen your fluid buildup. Your team might also prescribe water pills called diuretics to help you get rid of extra fluid when you pee. Diuretics can have side effects, so you'll need to get regular blood tests and keep track of your weight. This will help your team see how you're doing and decide if you need to adjust your diuretics. Let them know if you're dizzy, not peeing much, or losing weight quickly. If you have a lot of fluid buildup, you might need it drained with a needle. For ascites, or fluid in the belly, this procedure is called a paracentesis. Sometimes bacteria can grow in the fluid, causing a dangerous infection. Watch for a fever, sharp pain in your belly or chest, feeling sick to your stomach, or throwing up. If you have any of these symptoms, call your doctor or nurse right away or go to the emergency department.
Okay, so that's an excerpt from one of the videos, but it goes through a little bit of obviously the treatments for ascites. And so the main things just to reinforce would be reducing the amount of salt in your diet, water pills, which are diuretics, and we have a separate video all about those, and the different kinds of things that you need to watch for when you're on water pills. And then sometimes if the fluid doesn't go away with water pills, as mentioned, you can your doctor will order a drainage procedure. There are other specialized procedures, things called TIPS, or transjugular intrahepatic portosystemic shunt, which is a very long name, which is a shunt that's put through the liver to reduce, again, the pressure in the liver that Amin was talking about. And that can also be, in some people, a treatment for ascites. And so all of that information, challenging to cover all of that in this short talk, but all of that information is present on this page. So that is ascites. I wanted to also cover the other major complication, and this is one that can have a very significant impact on patients, because it alters the way that you think, and can really impact, you know, your interactions with people and your interactions with society in general. So hepatic encephalopathy or liver-related confusion. I'll play you a short video on that as well, and it will talk about some of the treatments and why this happens.
As well as confusion, toxin buildup can cause you to forget things and change your sleep pattern. So you might feel sleepy during the day and wide awake at night. It can affect your mood, so you might get upset or bothered more easily. It can also give you the shakes or cause you to have problems with balance. Encephalopathy can affect how quickly you react, so your healthcare team might tell you not to drive. Your healthcare team will usually prescribe lactulose if you have encephalopathy. This special laxative makes you have more bowel movements to help your body get rid of toxins. You'll need to keep track of your bowel movements and take enough lactulose so you have 2 or 3 soft ones each day. Take this medicine until your healthcare team tells you to stop. Rifaximin is another medicine that can help you manage encephalopathy. It changes your gut bacteria so they make fewer toxins. Some things can make encephalopathy worse, like infections, not having enough fluid, called dehydration, and bleeding. Some medicines can also make it worse, like painkillers and sleeping pills. Share what you learn about encephalopathy with your family and friends. They can help you watch for symptoms. If they notice you're not thinking clearly or are sleeping more than usual, they should contact your doctor or nurse right away. But they should call 911 and get you to the emergency department if they are having trouble waking you up or notice you can't talk, walk, or follow directions.
Okay, so again, a really short little snippet of hepatic encephalopathy treatment, but very, very important to know that there are medications out there that can help with these symptoms as long as they're taken properly and prescribed, and this condition is recognized. So many of my patients, unfortunately, if they're diagnosed with hepatic encephalopathy before meeting me, they are surprised actually that what happened. You know, we didn't actually expect that we could get confused with this diagnosis. So I think engaging with education to know that this is something that's possible will allow you to really be empowered if these complications do happen. Okay, the other major complication that Amin mentioned was varices, and patients with compensated disease can have varices, or these swollen veins in the food pipe as well. Decompensated cirrhosis is defined by actually bleeding from these enlarged veins. So let's just watch a little bit about the management of varices.
Varices. That's the medical term for swollen veins in the food pipe, your esophagus. You can also have varices in your stomach. The problem with varices is that they don't cause symptoms until they burst open and bleed. Many people can have varices and not know it. To check for varices, your healthcare team may want you to have a procedure called an endoscopy. You'll get medicine to help you relax. Then, a doctor will put a tiny camera through your mouth, down your throat, and into your stomach. If the camera shows swollen veins, the doctor may tie them off with tiny rubber bands to prevent bleeding. Your team might prescribe blood pressure medicine to prevent bleeding. If you take this medicine, check your blood pressure and pulse a few days each week. If you feel dizzy or lightheaded, let your doctor or nurse know. Also, check the color of your bowel movements. If they are black and tarry, or you throw up blood, or something that looks like coffee grounds, call 911 or go to the emergency department. This can be life-threatening.
Okay, so again, something to be aware of, and many people with cirrhosis will have already had had a gastroscopy done where the physician has a look in with a camera to see whether these veins are a problem. We're learning, just as a sort of maybe new use of an old therapy, these, just go down a little bit here, these beta blockers, which some people might be on, nadolol, propranolol, carvedilol. We're starting these a little bit earlier, even in the course of some patients' disease, in order to reduce the risk of developing complications like bleeding and like ascites. So that's something that you might see your doctor do. Okay, but you can get lots more information on both the gastroscopy procedure and the beta blockers on this page. Okay, I want to take you to one other complication, which is a very important one because it's something that we can detect again early, and if detected early, it can be much easier to treat, and that's liver cancer, which Amin also mentioned. So let me just play you this little short video.
The medical term for liver cancer is hepatocellular carcinoma, or HCC, but most people just call it liver cancer. It's an important type of cancer for people with cirrhosis to know about. Having cirrhosis is the most common risk factor for liver cancer. It starts as a small tumor in the liver that can grow over time. Not everyone with cirrhosis gets liver cancer, but it happens to a small number of people. If we catch liver cancer at an early stage when the tumor is small, it's easier to treat. But at this early stage, it usually doesn't cause symptoms. This means people can get liver cancer and not know about it right away. To help find liver cancer early, you might have an imaging test or scan to take pictures of your liver every 6 months. This is called screening. Screening for liver cancer in people with cirrhosis is usually done with an ultrasound scan. You may also have a special blood test to check for a tumor marker called alpha-fetoprotein, or AFP. Remember, the earlier we can find liver cancer, the easier it is to treat. So it's important for you to go for your ultrasound and blood test appointments.
Okay, and there are treatments again for hepatocellular carcinoma, and we do go into that a little bit more as well. But again, as with all of these complications, early diagnosis is really key. So the last little section that I want to talk about is an area that's really dear to my heart as well, is nutrition in cirrhosis. And before I go into the basics, I just want to show you some. You can see there's also exercise on here as well. We know from a lot of the research that we've done and many other sites across the world have done that as cirrhosis progresses, you do get more and more weak. And so you may notice that your muscles also get smaller, or you lose strength. And that's really important because it impacts how well you will do and how well you will be able to tolerate certain treatments even. And so to keep strong as much as possible, things like nutrition and exercise are very, very important, and they are something that, again, you can control. So I will go through nutrition a little bit. I want to, just before I go through the basic site, I want to show you this, which we've put together with a chef at one of the technology institutes here. And they go through so beautifully certain low salt, because eating low salt can be very challenging for anyone to take on. And so what Chef Maynard does here is he goes through how-to recipes with low salt. So how can you make things still be tasty despite having to do low salt? So he's got a number of things on there that can be used. How do you use marinades and rubs? So I learned a lot as well with this. So I will leave it to you to have a better look at that. And then there is also exercises actually on this site that can start you off. But this is something as well that's important to talk to your doctor about. Okay, so for cirrhosis, this is our last video that I wanted to show you because nutrition is so important. This is a slightly longer video and then I'll be done. But this is 4 nutrition tips, okay, that you can use to improve your liver health.
Let's go through 4 tips you need to know about fueling your body when you have cirrhosis. First tip, eat regularly. Eat every 3 to 4 hours when you're awake. This means eating 3 meals and 2 to 3 snacks a day, including a bedtime snack. Eating regularly helps to ensure your body has the energy it needs. Getting enough energy and nutrition can help you stay strong and supply you with the energy you need to do your daily tasks and routine. Second tip, eat enough protein. Talk to your healthcare provider about how much protein you need. Protein helps to keep your muscles strong and your immune system healthy. Protein can be challenging to get enough of if you're not feeling well. However, it is important that you eat enough protein at every meal and snack to make sure you're getting enough. See the Eating Well with Cirrhosis handout for a full list of protein foods, or you can read the nutrition facts tables found on food labels to learn how much protein a particular food has. If you want to learn more about protein, check out our videos that discuss protein. Third tip, let's talk about sodium. Sodium is found largely in salts and processed foods, though small amounts of sodium is naturally found in most our foods. When you have cirrhosis, eating a lot of salt or foods high in salt or sodium can cause you to retain fluid in your belly, legs, and even lungs. This extra fluid can make you feel full quicker, and it can make it difficult to get enough nutrition. In addition to limiting high sodium foods, you can also reduce the sodium in your diet by not adding salt to foods while cooking or at the dinner table. To get a flavor boost, add herbs like dill, oregano, and chili powder. Use salt-free seasoning blends, lemons and limes, vinegars, or garlic and onions. Over time, your taste buds will adjust. Check out our videos on label reading and low sodium cooking to learn more. Fourth tip, when you have cirrhosis, you are at higher risk to develop osteoporosis or weak bones through bone loss. It is important to eat and drink enough calcium and vitamin D to prevent bone loss. You can increase the calcium and vitamin D in your diet by having 3 to 4 servings of dairy or dairy alternates each day. You will notice that many calcium-rich foods are also high in protein, so including them can benefit you in many ways. If you are not able to meet your calcium and vitamin D needs with diet, your healthcare team might suggest a supplement. Be sure to talk to them about which one is right for you. Let's go through 4 tips you need to know about.
Sorry, guys. Okay, so that's the last video I wanted to show you, but I just maybe do want to touch on the fact that there are other complications and symptoms that people can have that fall outside of those liver-related issues. And so definitely these are things that you should bring up with your family physician or your liver specialist. Things like anxiety and depression can be higher in people who are suffering with cirrhosis, as well as things like muscle cramps, even pain, sleep problems, etc. So don't hesitate to bring those up with your providers. All right, and with that, I just again want to say thank you for this opportunity, and I think this should hopefully leave enough time for some questions.
Wonderful. Thank you both for those great talks. I continue to learn more and more as we have engaging webinars and educational events such as these. I would like to invite both our speakers to join us again on camera, and we're going to go into our questions and answers section. So if you haven't already asked a question on our Facebook Live, by all means, feel free to add whether it's a comment or a question in that feed, and we'll try to get to all those questions tonight, but also we'll be able to answer those questions later in the week, but also next week. The speakers will definitely help and assist and answer those questions. So I'll start with maybe just kind of an initial question. We did have a poll for what kind of type of questions people want to, I guess, raise prior to this webinar. And we've gotten a few, there's definitely some trends in terms of nutrition related questions, but also perhaps in staging related questions. So I'll just kind of maybe ask Dr. Ben Masood first. There's a question that pops up through our national support line quite often at the CLF, where people are wondering if their cirrhosis is reversible to any degree, whether they can slow the progress of the disease, or perhaps go to a stage where it is no longer getting worse. And a lot of times you hear different people say stories about people that they know that they've reversed the condition or they've prevented it from getting worse. So perhaps you can maybe shed some light as to if that's doable, what people can do, and kind of is there ways to help the liver recover from kind of the early stage cirrhosis or just cirrhosis in general. And Dr. Tennant, you could definitely jump in afterwards as well.
Yeah. Thanks, Nam. I think it is a great question. And actually, this topic has garnered even more attention in the recent years regarding specifically regression of liver disease and also cirrhosis. As Dr. Tennant and Britta has mentioned, a very important aspect we want to do is to slow down the process of anything that's active. And so if you can target the underlying cause of the liver disease, right? If it's alcohol, stopping to drink, if it's fatty liver and maybe gentle weight loss, hepatitis B, controlling the virus, hepatitis C, getting rid of the virus, all these things by decreasing the ongoing inflammation will definitely help slow the process. And even in some individuals, rarely, but it does happen where, depending on how bad the scarring is, you might have a chance of a bit of regeneration and maybe help in that sense. Another thing that we discussed and Dr. Tennant mentioned, so beta blockers, non-selective beta blockers, in a recent study that showed that even people with cirrhosis, if initiated early on, maybe it won't reverse it, but at least it will stop the portal hypertension from getting any worse, and therefore decreasing the chance of decompensation.
Punita, do you have anything to add on that?
Yeah, no, that's great. I think Amin covered that. So there are things that you can do, and I know that everyone's keen to find different medications like anti-fibrotic agents or other anti-inflammatory medications that can help. So be assured that those things are being tested. We don't have anything available right now for everybody's use, but hopefully things down the pipeline at some point.
Great. There was one question that was raised regarding nutrition. It was relating to protein consumption. The question was, does protein consumption make a significant difference when trying to minimize the effects of cirrhosis?
Yeah, it really does. It's, I mean, you need a balanced diet, so you can't just eat protein, obviously, which is why it's so important to, engage with a dietitian if that's possible, and if that's not possible, then obviously really looking at the resources that are available. But protein itself is one of the main components of building muscle. And so we know that when we looked at our data of about 600 patients who are waiting for transplantation, only about 25% were actually meeting protein targets. Mm-hmm. And when studies look at giving people adequate amounts of nutrition, even giving them a late evening snack, which is, again, a very important piece for cirrhosis, because we know, we didn't go into this too much, but when you get cirrhosis, your liver can't store glucose or glycogen as well. And so any period of starvation is actually dangerous. And so overnight is a period of starvation that all of us are used to, but that's sort of the riskiest period. So it's recommended that every patient with cirrhosis take a late evening snack to bridge that gap. And one study showed that just taking that late evening snack, they divided it, either taking it in the mornings, for half the patients are taking it in the evening period. So I think it was 9 p.m. to 7 a.m. kind of thing. You increase your muscle mass by 2 kilograms in that study. So you can really make a difference with changing your nutrition. Yeah. And I'll just add on to that, as the video suggested, eating a variety of proteins is also important, because it's tough. It's tough to get in the recommended 1.2 to 1.5 grams per kilogram per day. So increasing things like lentils potentially, or adding other things into your diet that you don't normally eat, might be helpful. And some of those videos that the chef created can help you to get some ideas for that.
No, it's great. And it's one of the more common questions that relate to nutrition. And as we all probably have tried in the past, or know friends who've tried it, no specific diet works for everyone. And it is a matter of patience and trial and error, but also trying to understand your body and what you can respond to well. And this is where these conversations, the healthcare providers and the healthcare team are extremely important. There's
Yeah.
just one question that did get raised in terms of, I guess, longevity or what they call prognosis, or how well can somebody live with cirrhosis, whether it's assuming someone does have no specific symptoms or no complications, or if they do have severe complications. Is there roughly kind of a time span, or how long can somebody expect to be in a controlled or manageable state of their cirrhosis relative to perhaps their quality of life being affected within a year or 2 years? Is there roughly some research indicating in terms of how that works? Those are some of the common, I guess, unknowns that people tend to raise. So any kind of light on that would be great.
Yeah,
Did you
if
want
you
to
want. Yeah, of course.
Okay.
So there are some great studies published in the early 2000s by D'Amico, really well-known Polish author, and liver diseases, that looked at people that have compensated cirrhosis and looked at what we call the median survival. Median survival means how many individuals, how long does half of the population survive, basically, so 50%. And for individuals with compensated cirrhosis, the median survival is thought to be at around 10 to 12 years, which is a really good start. And then, that gives us, again, the opportunity to work on the preventing complications and treating the underlying causes. Once you come in with decompensated liver disease, whether it's variceal bleeding, ascites accumulation, or hepatic encephalopathy, unfortunately, the median survival is shortened significantly. And now each condition has a different prognosis, but suffice to say that about the median survival is thought to be at around 2 years. And that's where linking up with the medical providers and hepatologists is very important to try to correct and try to maintain individuals in as best health as possible from their liver point of view. But again, I think another really important one that's coming up more and more recently is how the importance of nutrition is in individuals with decompensated liver disease. And if you are able to maintain a good nutritional status, you're actually going to help yourself achieve that longer longevity as well, I think. Anita, if you want to add.
Yeah, I think, and numbers are really important to have, but again, that's like I think you said, NEM, right? Everybody's coming in as an individual, and so it's really difficult to peg a particular number, especially because everyone comes in with their own comorbidities and how old they are and how much reversibility there might be of their condition. So those sort of discussions, I think, are really important to have with your healthcare provider, because they would know you best as far as what that situation is. But certainly once decompensation develops, that's something where your healthcare provider team would think about liver transplantation potentially as an option. And that's not an option in all people, or not well suited for all people, but that's certainly something that comes up. But there are things, rest assured, that we have covered that can help to improve not only your quality of life, but also your quantity of life.
I guess speaking of transplantation, there was a question that was asked earlier in the week in terms of what I guess may perhaps disqualifies cirrhotic patients from being on the transplant list, or perhaps why some patients are not eligible for a transplant. Understand that, of course, it's a staging and severity issue. We get a lot of caregivers who get placed in very difficult situations, and they're wondering what they can do on their end if their loved one was not placed in the transplant list, and perhaps that was the hope at the beginning, and it is no longer ideal. So any kind of tips in terms of from the caregiver perspective, what perhaps they can expect if a transplant's not in the future? I know we touched on kind of long-term, but I guess there's a lot of unknowns still floating around with cirrhosis that perhaps both of you could kind of connect on or touch on.
Yeah, and I think if, there's many contraindications that the team would consider, and indications as well. That any team, we want to list people for transplant. So that's our goal, is to really try. So if we're not listing, there's something that is making that procedure unsafe, or making it that it's unlikely that it's going to cost benefit necessarily because of something related to maybe the physiology or the patient's situation, social situation or other circumstances as well. And that can be a devastating news to not be listed for transplantation. So one of my main areas of interest is also something called palliative care, which has various different names for symptom management. And those are a specialized team of doctors who specialize in having these difficult conversations and also specialize in helping people through these periods of uncertainty, which, right at the beginning of the diagnosis almost is a good time to get some discussions going about this very openly with your doctor. Say, hey, what does this look like for me? And how can I do my best to help the situation, and who can I talk to if I need help to manage some of the emotional distress, etc. The patient or obviously the caregiver, who plays an incredibly important role alongside the patient in all of this.
Great. Dr. Ben-Masood, anything to add on your end?
Well, like Dr. Tandon mentioned, I think these can be quite stressful and difficult situations for patients who are also caregivers, which are present with them quite frequently. And I think that's where having these teams around you that can help and guide the discussion and, educate, share a bit of knowledge, and try to, help people understand maybe what's ahead. And so being aware of what's coming sometimes can provide a bit of reassurance in terms of knowing what could be coming. But I think that's why I'm in hepatology, and I've going through training and so on. Having these links with our patients is something that's extremely important to all of us as care providers.
Great. There was one question about earlier in terms of with respect to autoimmune liver disease. I know you mentioned it's not as common as some of the main primary causes. Are there any differences in terms of treatment or management or progression, or if it gets worse, if the cause of their cirrhosis was autoimmune, just because there's a lot of unknowns there? Is there a difference between not being able to address a cause like PBC or PSC, but being able to address alcohol or NAFLD, for example? Does that cause any difficulties or challenges in terms of treatments or anything different in terms of kind of care with those specific cirrhosis patients?
So I specifically relate to, like you mentioned, autoimmune. So we do have good treatments, which specifically corticosteroids, or also which often we can combine with other medication, try to minimize the amount of steroids that we might have to give people, and that's really to a bit decrease the inflammation, decrease the immune system so that there's less inflammation. And similarly, we see great work too when we start with people with a lot of inflammation. We give them steroids. We're able to achieve normalization of the liver enzyme, and even when you take a biopsy, you might see a normal liver. And I think that's extremely positive for that patient, knowing that you've removed the main driver, or at least you've controlled it for now. And the important thing about these conditions is that they'll need long-term monitoring and long-term follow-up with the healthcare provider, and that's how you'll decrease, a flare or a recurrence of an autoimmune hepatitis, for example. PBC, because you've mentioned it, primary biliary cholangitis, we do have fantastic treatments, ursodeoxycholic acid, which we've had for numerous years. And now for the 20 to 30% that didn't respond that well, we now have a second agent that can be offered called obeticholic acid. So there are possibilities. PSC is one with a lot of research is involved, and we're hoping, again, a lot of things in the pipeline to try to help people with PSC to try to get a control over the inflammation.
Oh, great. Dr. Tandon, anything to add on your end from the autoimmune liver disease side?
Yeah, no, I think that was great. Yeah.
Great. We'll just finish with this kind of one last question, I guess. During the pandemic, there's been some articles, some different research in terms of rise of advanced or severe liver disease over the last perhaps year and a half. Have either of you, from your professional or clinical experience, noticed this increase? There's a patients with severe liver disease and perhaps what some of the causes were, and in terms of kind of what people can do to not get into those habits of whether they were dietary habits, whether it was behavioral or anything of that, in terms of potential screening, anything that they can do, given the pandemic is still going on with some of the restrictions in different provinces, that maybe you can shed some light from your kind of clinical professional perspective.
Yeah, if you want, I can. So Nam, I think, thank you. This is an extremely important question because we can't stress enough, and I think Punita mentioned, there's a lot of different conditions that are associated with liver disease, whether it's ascites, bleeding, confusion. And in times of pandemic, people were concerned initially of going to the hospital. They were scared because they were concerned that they might catch COVID, or, so that sometimes can lead to delayed presentation. And so if you have some of these serious complications, or if you're not feeling well for whatever reason it could be, whether it's liver or something else, if you're having chest pain, for example, don't hesitate to seek medical help, to seek urgent medical help. And that's where you'll be best taken care of. And hopefully now that people are getting vaccinated, and also echo the sentiment that we should get out there and continue the vaccination efforts, which will slow down, again, transmission and decrease the load on our healthcare system, so that people, if they're less concerned or afraid to go to the hospital, but please do if you're concerned.
Yeah, and then just to add to that, I mean, I think that it's natural for people to fall back on, coping mechanisms that had been used before, like alcohol, for example, or eating. And that's happening not only in people who have cirrhosis, but just across the board in society. So we are seeing that, and recognize, that your healthcare team is there to try and help to support you through that. So do reach out, because there are medications that we can use, for example, to reduce cravings for alcohol, and there are other support strategies. And similarly for eating, there is liaising with a dietitian, just even to talk about what's going on might help, or psychologist to help, etc. So reach out for sure.
That's great. No, thank you for that. And we'll conclude with that, those final very intriguing and very, very helpful points by both our speakers. We have a few questions that we can definitely answer through our feed over the next few days and next week. We'll seek some assistance from both our attendant and other Masu to assist and answer some of those questions. But I do want to thank both Punita and Amin for the great talks today. It definitely sheds a light on cirrhosis and what people can expect with the condition, but also what they can do from a prevention standpoint as well. I do want to thank, of course, our partners at the Canadian Association for the Study of Liver for their help and their assistance with this webinar. And as we mentioned, this webinar, along with other cirrhosis-related resources, including the cirrhosiscare.ca website, will be available on our liver.ca website. This webinar will be available on our Facebook page as well, and our YouTube page over the next few days. You can visit us at liver.ca/cirrhosis for a quicker link to the page. And over the next few days, we'll add an extensive resource library at the bottom of the page that has all the helpful links that Dr. Tan and Dr. Masood have been mentioning throughout this talk. And of course, to learn more about cirrhosis and all other liver diseases, or to find out about what we do at Canadian Liver Foundation, please visit us at liver.ca. And be sure to follow us on social media, our Facebook, Twitter, and Instagram accounts for all the most up-to-date information and liver health tips. So thank you all again. We hope you have a safe and wonderful evening, and thank you for joining us. And we hope everyone enjoys the rest of their day and their evening, as well as the long weekend coming up. Thank you, and have a great